Good to go. Hello, everybody, and welcome to this installment of the Practice Perfection Education Series. I'm Danny Bobrow, President of AIM Dental Marketing, and it's my pleasure to once again welcome to the Practice Perfection stage another luminary of oral systemic health. Angie Stone, RDH, BS, has practiced as a dental assistant, patient care coordinator, and clinical dental hygienist. She was editor-in-chief of the hygiene publication, Hygiene Consultant, and has been on the faculty of both dental assisting and dental hygiene programs. She is an internationally sought-after speaker. I know she just spent the majority of her last 4 weeks overseas, and has educated dental professionals in 35 states and 4 countries. Her articles have appeared in a variety of publications, and her research regarding xylitol and the elder population has been published in the peer-reviewed journal Integrative Medicine. Her company, HighLife, brings oral care services to seniors in nursing home environments because, as her company's tagline states, they shouldn't die of dirty teeth. In 2012, Angie was awarded the Sunstar RDH Magazine Award of Distinction for her work with xylitol and the geriatric population. Her book, Dare to be a Difference Maker, was released in December of 2013, and we want to congratulate Angie on the rave reviews it continues to enjoy. And speaking of books, Angie, why don't you tell our viewers about what's happening this Saturday?
Oh, Danny, thank you so much. We're super excited. We are launching my new book called Dying from Dirty Teeth with a book signing event and a book launch at our local library. So we're super excited to launch the book and get this information out to the people so that we can make a difference in the lives of our elders.
Well, you already have, and I'm certain this will allow you to continue to do so in even a bigger way. Congratulations, Angie. That's great.
Thank you.
And you are welcome. Thank you. I'm also pleased to again welcome our underwriter for today's broadcast, Aseptico, manufactures and distributes mobile dental delivery systems, as well as the wand anesthesia delivery system. They help you to get to yes with your patients, making them the perfect practice perfection partner. Today's event, as usual, is set to run for approximately 90 minutes. We invite you to feel free to submit any questions you have using this question form on your screen. We will then do our best to get your questions answered following the presentation. If we're unable to do that, Angie has agreed to respond personally following the presentation. The webcast is being recorded, and you will receive a link to it soon. And along with the email, you will receive a quiz which will qualify you to receive 1.5 hours of CE credit. We just need to get some completed quiz from you within 30 days of the broadcast for you to qualify. And now, it's my distinct pleasure to once again welcome to Practice Perfection my dear friend, Angie Stone. Hello again, Angie.
Hello, Danny. Thank you so much for having me provide another webinar for your listeners. I'm just super excited to be here and super excited to share our message about the elders and how we can make a difference in their lives. And I'd like to take just a second to thank Aseptico for underwriting this webinar, because without that we probably wouldn't be here tonight. Is that right, Danny?
Well, we would have probably found some way, but they certainly made it a lot easier, didn't they?
Yes, they did. That's awesome. So thank you to the people at Aseptico. We really appreciate your assistance with this and appreciate the products that you're putting out there for people to provide mobile dentistry. Without these products, it would be a lot harder to serve this population and our children and everything with mobile dentistry, so thanks a bunch. So we're going to go ahead and get started here with the presentation, Dying from Dirty Teeth. Life expectancy in 1900 was just over 47 years. Life expectancy in 2004 was just over 78 years. So look at what we're doing as far as increasing the length of our lives. And look at what they think we're going to continue to do. Life expectancy in 2050 is projected to be just about 83 years old. This is what good medicine does, right? And it's not stopping. It's interesting to me that 5% of Americans over age 65 live in a staffed facility, and 50% of those 95 and older lived in a staffed facility. There are about 16,000 nursing homes in the United States, caring for over 1.5 million people. And this is from the 2004 National Nursing Home Survey, and oddly enough, that's the most recent nursing home survey. 55 million people in the United States will be age 65 or older by 2020. And this blows my mind. Beginning in 2011, 10,000 people per day are turning 65 for the next 20 years. And if we do some math, which I'm a hygienist, as Danny mentioned, and I went into hygiene because I only knew I had to count to 32 to be a hygienist because math isn't my strong point. But if we do the math on this, we're going to have over 7 million people over age 65 by the year 2031. Big deal. Who cares? Who's really thinking about this? I will tell you that I didn't even think about this until I had someone in my life that was residing in a nursing home. And the person you see there on the screen with the arrow going to her, that's my mother-in-law. And that was many years ago. Our children are now 24 and 20 that you see on the screen. But what happened to Gladys is she ended up in a nursing home because she had COPD, which is chronic obstructive pulmonary disease. And what we know is that the condition of the lungs is absolutely affected by the mouth. And what I was watching was I was watching her periodontal disease progress, and we could not keep her lungs clear. I hadn't been a hygienist for very long at that point, and there are laws and things that prevent me from cleaning teeth in a nursing home without a dentist. There wasn't a dentist at the nursing home, and I wasn't really sure what to do, so I just watched this happen. I watched her be sick with her COPD, and I watched her mouth be infected at the same time. And I knew as a hygienist that her mouth was affecting her overall health, but no one else seemed to know that. So they'd give her antibiotic after antibiotic, and things would clear up for a little while, but then guess what? The infection in her lung would come back, and her lungs would come back. She eventually lost her life to COPD, or did her dirty teeth, her periodontal disease, compound that COPD and cause her death? Interesting to talk about, huh? So when Gladys died, I vowed to her that I would do something. At that point, like I said, I'd been a hygienist for maybe about 3 years, and I didn't know exactly what to do, so I started to look. What things are being done for our elders? And at that point, there weren't a lot of things. This was in 2003, and there still aren't a lot of programs for our elders. I couldn't find anything. What I did find, though, were a lot of things that were geared towards children, which I understand. But there are people at the other end of life that need our care. And as all of this is going on and I'm trying to figure out what I might be able to do, I'm starting to worry about these two clowns that are on the screen right now, and those are my parents. I'm like, what the heck am I going to do if my parents end up in a nursing home and they die or they're sick because of complications in their mouth? I'm not going to be able to live with myself. So this has been a burning issue in my brain. So again, I started looking around. Now, mind you, all this is going on while I have a full-time job, and there isn't really any money to be made at this point with what I was doing. So every time I was busy, it seemed like something else came up or I read something and kept this nursing home thing in my brain. So again, looking around, I found that there were many resources to help our children. We do a lot of things for the kids. We have Seal a Smile programs, we have Head Start programs, we have fluoride varnish programs, we have American's Tooth Fairy, we have oral health coalitions, We've got Children's National Dental Health Month. And we need these things because these children rely on us. They're dependent. And they don't know what they don't know. So it's our responsibility to take care of them. And we do that quite well. But what about the other end of the spectrum? What happens to these people as they age and they're dependent? Shouldn't we be taking care of them as well? These are things that run through my mind. And I came across this statistic, which very much frightens me. Elderly nursing home residents have extensive oral disease and poor oral hygiene and suffer the worst oral health of any population. This to me doesn't make any sense. Why do we have this statistic? So I started thinking and doing some more digging, and I think part of it is because of the current resident situation. These people that are in nursing homes currently are either of the civic generation who were born in the 20s or of the silent generation who were born between 1930 and 1945. And when we think about the kind of dental care that this population has had, it's really not what we're accustomed to at this point in time. They weren't accustomed to regular dental visits. They typically only went when they had a toothache, and the option for them was usually to have the tooth extracted. They really weren't practicing endodontics. So as a result of these things, they may have had multiple extractions, and they may have partials or dentures. By virtue of the dental technology available in these people's younger years, they're no stranger to decay and extensive restorations. And I like to, when I'm at the podium and I'm talking about these extensive restorations and decay, we know that recurrent decay is going to start around these restorations. It's kind of like in Wisconsin, which is where I'm from. When we have rust and we repair the rust, we're going to get more rust around the bondo. It's the same with our restorations. We know that they're going to decay first around the restorations. So when you have big restorations, as this population typically does, they are sitting ducks for recurrent decay. They are also sitting ducks for periodontal disease because they're not getting dental services. The woman you see there on the screen is my gram at age 90, and she passed away. Maybe she's 91 in that picture. She passed away at age 93, and we're going to talk more about her in a little bit. But I think if we look ahead, our residents are going to look very different. Our nursing home residents are looking very different. The boomers are coming. The baby boomers, depending on what you look at, what statistics you look at, are born between 1946 and 1964. And think about that population. Maybe most of us on the call are in that boomer generation, or maybe just early into the next generation. But we have received very different dental care. We are used to regular dental treatment. We are going to more than likely come to the nursing home with a full complement of teeth, which will be at more risk for decay and periodontal disease simply because we're going to have more natural teeth. And a lot of you on this call are probably doing some pretty high-end dentistry, like implants. You might be doing veneers. And what's going to happen to all of that fancy dental work if these people are unable to take care of themselves? I hate to tell you, but it's probably going to be no different than what's happening to the teeth in the nursing homes now. And they're breaking, they're decaying, and there's rampant periodontal disease. Personally, I don't know why we don't see what's happening. It's almost like we're just sticking our head in the sand. It's like, well, you know what? Those people are old, and there's nothing we can do to help them. I don't really agree with that. So again, in my travels and learning things, I was trying to figure out how can we improve that statistic. That statistic haunts me because it doesn't have to be. So I was like, well, what would be the best case scenario? Well, of course, we would think traditional dental office care, just the way everyone else gets care. Dentists would provide the restorative procedures, and the hygienists provide preventive and therapeutic services to this population. Why is that not happening? Well, it didn't take me looking very far, and as a hygienist myself of 15 years and 30 years in a dental office, I know there's complications to getting this population into our chairs. The biggest hurdle is money, and I had a college professor that told us that the bottom line is always money. And throughout my life, I've kind of figured that he was right. So this population doesn't have private insurance. They typically don't have any cash laying around to pay for dental services, and Medicare pays nothing towards dental care, and Medicaid pays very little. And I bet you all know of the situation in the states that you're from, that there just isn't a lot of provision for these folks. Look at how much it costs to live in a nursing home. $76,000 a year for a semi-private room. If you want your loved one in a private room, then you need about $86,000 a year. Where is there going to be extra money coming from if you need a lot of extra money for outside services? And these folks don't have transportation. They don't have a private vehicle, and if they did, they probably can't operate it, and we probably wouldn't want them to operate it. And they don't have any family to transport them, most oftentimes. Now, there are some exceptions to the rules that family members are really good. But I don't know if any of you have ever hung around a nursing home like I have. The families can be pretty sparse. So some of the facilities have come up with their own transportation. There are some challenges to this as well. These vans are very expensive to operate. They need to pay staff to operate the vehicle. They then also will need a staff member to travel with the resident. So these facilities are typically understaffed anyway. And so now if someone has an appointment, whether it's at the dental office or whether it's at the doctor or wherever it is, they send a person with the resident, and now they're even more short-staffed. So they're not all about getting people out of the facility. And when the residents are mentally unable to be transported or mentally compromised, taking the residents out is really very, very difficult, and getting them out of the facility, even getting them into the car and taking them to somebody they don't know, compounds their anxiety and their dementia. So now when the resident comes back to the facility, they're all agitated. And the last thing that people that are short-staffed need are aggravated residents. So getting people out to the traditional offices is difficult, and many of our offices are not equipped to treat this population. I don't know that our operatories are really all that able to have wheelchairs in them. I don't know that many of us are able to do wheelchair transfers. I don't know many hygienists that are able to transfer a resident, that we've been trained to do that and that we feel comfortable doing that. And then the nursing home resident will likely come with a big manila envelope like you're looking at. And I think you all know what I'm talking about. It's this big, thick packet, and they come in and they give it to you, and you're supposed to make your dental notes somewhere within all these pages. And we look at the med list and we're like, well, holy cow, I probably should have started looking all these up in the PDR 2 weeks ago. So now we're behind schedule. It's very difficult to see these people in the dental office. And I believe that these challenges that we face are one of the things that leads to the statistic of elderly nursing home residents having extensive oral disease and poor oral hygiene and suffer the worst oral health of any population. You're going to hear that about 6 times tonight, because this is what we're talking about. And not only is it the oral disease, but it's the systemic disease that they're going through too, if their mouths are not taken care of. So it's like, well, okay, if we really can't get our patients out to the dental offices, what if we could have in-facility dental care? I'm like, well, this is kind of seemed like a no-brainer to me, right? We should be able to see patients in the nursing home. Well, in Angie world, which my husband thinks that I live in a fair amount of time.
Define Angie world, Angie.
What's that?
Ideal? I said define Angie world for us, although I suspect you're about to.
Yeah, I am. So in Angie world, these offices in these nursing homes would be, we'd have modern dental equipment, we'd have a dentist on staff, we'd have the appointments made by a scheduler, the patients would be cooperative, and all patients receive hygiene services. And I'm like, well, this just seems like so easy to me. But guess what? It's not. This is a dental office that I actually worked in the basement of a nursing home. I had been doing in-service trainings at this facility for quite some time. Every 6 months I'd go in and do in-service trainings. And during one of the in-service trainings, one of the nursing assistants leaned over to her friend and whispered she should see the dental office in the basement. But I heard them. I'm like, what are you talking about? And they said they had a dental office. I'm like, well, after this in-service training, we're certainly going there. I want to see this dental office. Well, this is what I saw. I'm like, wow, the chair doesn't go up and down. Look at that headrest, right? But I was like, at least it's something. At least it's something. So in Wisconsin, I can bill Medicaid directly for my services. I do need a dentist, though, to do an exam before I can see the residents. So they had a dentist on staff who would pretty much just do denture adjustments and the exams. So I wrote a proposal to the county home, this was a county home, nursing home, about what I would need to set up and do hygiene services here. And they accepted the proposal and got me the things that I needed. But who in their right mind really is going to want to operate here? I don't know of any dentists that are in their money-making years are really going to be interested in this kind of equipment. And that's what I've found, is that this is not the greatest place for a dentist, and I get that. They don't get compensated very well. It's a difficult population to work with. What I learned is that most of my patients couldn't even get into that chair, so I saw them most oftentimes in their wheelchairs, and that's backbreaking. One summer I did in-service trainings in 20 nursing homes in southern Wisconsin, and only one had an in-house dental treatment. And there was no hygienist on staff. It was a retired dentist that was doing the dentistry and the dental hygiene. So it didn't take me very long to figure out that this isn't as easy as what I thought. And this was so interesting to me. I had this man by the name of Sam Perlin, who is a long-term care advocate and consultant in Texas, out of the blue email me. There are companies that are trying to provide services. And what Sam told me is that there's an organization in Texas which they consider to be a rip-off of Medicaid funds, and besides not providing resolution to the concern of dental care. These residents have something called applied income. Not all residents have it. I don't know how some do and some don't. But those that have applied income are paying $238 a month for dental care. And what they're finding is that the dental care isn't even being completed. And I have got another story that you're going to hear about later about the same type of a thing, is that I'm not saying that all companies that are doing this are not doing a good job, but in my travels, I've heard of more that are not doing a good job than that are doing a good job. So Sam goes on to say just the 12 members at one nursing home is costing Medicaid over $34,000 a year. This is just for one facility. There are 1,100 nursing homes in Texas. If this organization signed up 12 residents in 10 facilities, it would cost Medicaid about $350,000 and $700,000 if they signed up 12 residents in the 20 facilities.
This is, Angie, let me interrupt. This is a private organization. It's essentially trying to privatize the delivery of dental care through the nursing home system?
Yes.
Or how would you just? Okay.
Yes. And so
and this is something that you learned about through this gentleman, Sam, who is in Texas. Do we know how prevalent or how representative this is of the rest of the country?
well, I've had a hygienist come to me that worked for this kind of a company that is infiltrated in Florida and the southeastern states. I'm sure that this company in Texas is in other states as well. This hygienist called me. She was out of her wits. She's like, Angie, I can't do this anymore. I don't know how you can help me. The dentist, they tell these people that they're going to have dental care. They get their exams, and unless they're in pain, they don't get anything else. And you're gonna hear about the incident I had with my grandmother in a nursing home under the care of a nursing home program like this. And so I've not heard a lot of great things across the country.
I mean, because on the one hand, it's encouraging to hear that there's at least an attempt. It's like a privatization strategy. But obviously, if the research, assuming there's any research being done, for outcomes, if the outcomes are not positive, then this is something worthy of concern. It sounds that, to me, unfortunately, that's what it's appearing to be. That's why he uses the term ripoff.
Yes, and I don't, again, I can't paint all of the companies with the same brush, but I can tell you that I've heard enough feedback from enough people affiliated with enough companies that in my mind, if I hear of a company that's doing this stuff, you better darn tootin' that I'm checking it out before, I would be involved with that or anything, because it's really hard to get to all of these people that need care. And I get that, but it's like, don't tell them they're going to get care if they're not going to get it, and then don't tell me that they only get care if they're in pain when your brochures tell me that they're going to get all their fillings done and they're going to get dentures or partials, and then they don't get it.
I'm guessing that also that it's optional. I mean, I'm assuming that nursing home had more than 12 residents in it, but only 12 opted to or could afford this program. Okay.
Yes, and so it's those ones, in Sam's case, it's those ones that have those applied funds. And again, I'm not the guru on the Medicaid and the applied funds and all that stuff. So I don't know exactly how that works, but there is something that some people have a little more money than other people, so it oftentimes feels like there's money to be had, so someone's going to have it.
Okay, thanks for that clarification.
Doesn't sit right with me. And so because it's difficult to get the dental services or dental service excellence with this population, it's another reason that we have this statistic. So I was like, oh man, so there are, for the masses of nursing home residents or dependent elders, even homebound. Okay, so I've really found out that the masses of them are not going to be able to get our services in an office. The masses of them are not going to be able to see a dentist or hygienist in their facility. So what the heck is the next thing? So I was like, what about, we hear a lot about direct access to dental hygienists. So we know that if we're doing prevention, that we would have less dental services that are necessary. That's the whole goal here, is to keep our patients healthy so that they don't have dental disease. And without dental disease, we know that their whole body is going to be healthier. So I was like, well, if we could just get the dental hygienists in the nursing facility and at least provide hygiene services, right? So this is all over the board across the country. There is nothing in every state that is exactly the same, which I think that if we had a blanket law rather than 50 different laws, we could make a better impact. I went to the ADHA, and this is what they had on their website, that we have direct access in 36 states. And I found it interesting that for the purpose of this document, direct access means that the hygienist can initiate treatment based upon his or own assessment of the patient's needs. That's good. Without the specific authorization of a dentist, treat the patient without the presence of a dentist, and can maintain a provider-patient relationship. That sounds pretty cool. However, when you go to look at their how these direct access things are written, there are only how many states without any constraints? And the answer to that is 2. So if you go down and you look at all of the states that their laws about direct access or their public health hygienists, things like that, every one of them except for Colorado and Connecticut will mention at some point in time that we have to have a dentist. But in Colorado, there's no requirement that a dentist must authorize or supervise most hygiene services, except for local anesthetic. And in Connecticut, if the hygienist has 2 years of experience, they may practice without supervision, and they can provide their services. If you look at the other rules of the other states, it may say that we can start the treatment, we can do a hygiene visit without having the dentist look at the patient first, but then at some point in time, we need to either collaborate with the dentist, or we need to have that dentist actually see the patient. And this is hard to do, you guys. You know, it's just not that simple. I just spoke in Alaska, and I had 101 hygienists in my group, and they have collaborative practice agreement there for these environments. And we make that look like that's the end-all be-all. You know how many of those hygienists in that room were working collaboratively with a dentist? 1. So there are still hiccups to getting the hygiene services. And I'm not faulting anybody. You know, I don't fault the dentist for not wanting to spend their time at the nursing home. Why would they? Again, the masses of them. There are a lot of dentists that would work with this population, but not the masses. There's not enough dentists interested in this population to treat everybody. And I'm not so sure that I would want to either if I were a dentist. When I can have an office, I can have great equipment. My patients come in, they sit in my chair, they open their mouth, they walk out, they pay, and now I'm working with another population that is completely different. But hygienists don't even have direct access to them to provide services. So we can't even get in there to give them clean teeth once every 3 months or once every 6 months, however long they need it, because we've got to have an agreement with the dentist, or we have to have a dentist that is willing to go and do the exams. This is another barrier to care for this population. You know what though? I've cleaned teeth in the nursing home, I told you that, and I would see my patients every 3 months. And what I saw was that even when I was cleaning the teeth every 3 months, they came back to me and they were a mess. So in my brain, the question is, if all elders had access to dental and dental hygiene services, would this statistic still remain? What do your patients that can't take care of themselves look like when they come back to your office in 3, 6, or 12 or more months? They are a mess. Most oftentimes, if they can't take care of themselves. So the real problem, I think, is that most dependent elders are unable to perform basic oral care tasks. They can't do it themselves, just like children can't do it themselves. We help the children, they're dependent. These people have a decline in their physical abilities, in their mental abilities, and they can't do it by themselves. And because the dental profession is not present in these facilities, the basic oral care is left up to the nursing staff. And there are some real problems with that. And that's what we're going to talk about next. Registered nurses and certified nursing assistants have minimal education in the area of health care, but they're the ones responsible for the oral cavity. Doesn't make sense to me. They have inadequate oral care education. Basically what they're taught is instruction in brushing and flossing. The nurses, that's about what they get. And the nurses are not the ones that are providing the daily oral care for the residents. The task is delegated to the certified nursing assistants, or whatever you call it in your state. In Wisconsin, it's CNA, Certified Nursing Assistant. CNAs aren't even required to have a high school diploma or work experience. But if they work in a Medicare or Medicaid certified nursing home, they must complete a minimum of 75 hours of training and pass a competency evaluation within 4 months of employment. The 75 hours is completed at the facility and not in a formal CNA program. In that 75-hour training, they get about a half an hour of instruction on oral care. That is hands-on and book. And the books that they use are typically written by nurses. Nurses are not the authority on oral care. The texts share very little information regarding oral care, and they discuss and show pictures of brushing, flossing, and denture cleaning. That's what they get taught in 30 minutes. This is an example of what you would see in a CNA textbook. Care of a person's mouth is called oral hygiene. A sick person's mouth often has a bad taste because of medications or the illness. The tongue may be covered with a grayish coating that spoils the appetite. With good care, the patient's mouth will feel fresh and clean, and they may increase the desire to eat. Is that what a dental professional would teach a CNA about oral care, the importance of oral care? They tend to focus a lot on eating, because if residents lose weight in a nursing home, that's not a good sign. And people that are looking at the nursing homes don't like it when residents lose weight. So the mouth is being tied to good eating. This is another one. Giving good oral hygiene is an essential part of daily patient care. Teeth should be brushed every morning, every evening, and after eating. Flossing teeth once a day is desirable and will promote healthy gums. In your work, you will be giving oral hygiene to conscious and unconscious patients. When necessary, you will be cleaning your dentures. Well, at least now we're talking about healthy gums. But I am telling you that it is impossible for these CNAs to brush every resident's teeth every morning, every evening, and after eating. They're taught not to put their fingers in someone's mouth when they're on the floor at the nursing home. So this right here goes right out the window as soon as they step onto the floor at the nursing home. It's kind of like, as dental professionals, when we got out of school as hygienists, we were still having a couple of hours for a hygiene visit. And all of a sudden, we're in the dental office, and we have an hour. Something's got to give. So what do we throw out the window? Well, blood pressure screening goes, probably one of the first things, potentially. Looking up all the meds in the PDR goes out the window pretty quickly. There are a lot of things that have to go. Brushing the teeth every morning, every evening, and after eating is not happening. It's not possible. This is me. Well, I mean, that's not me. Those are my hands. And I'm trying to get into this woman's mouth, this resident's mouth, and she was not having it. And so I spent a lot of time trying to get into her mouth. And this is what I saw. That's terrible. And I bet that if a CNA was looking in that resident's mouth, if they could even get in there, if they could even spend the time to coax her to let them in there, they would not know what they're looking at. This is a man that I was trying to get into his mouth, and I had the dentist at the facility standing over my shoulder telling me not to bother trying to get into this man's mouth because he had no teeth. Look at my knuckles, how hard I'm working to get into this man's mouth. He had teeth. The dentist didn't even know he had teeth. So why in the world would we think that an aide with 30 minutes of education on oral hygiene is going to be able to help this man's mouth? They are taught to tell the nurse when they're assisting with oral care that they're supposed to pay attention to the following: bleeding gums, foul odor, broken teeth, sores in the mouth. Which makes sense to us. We would know exactly what we're looking at. But when you're taught and you're only shown pictures of toothbrushing and flossing, they have no idea what they're looking at. None. Do you think that an aide is going to know exactly what's going on here? No? It's pretty sick, isn't it? What about this one? Do you think anybody's going to know what's going on here with 30 minutes of education? They just think the teeth are yellow. In their textbooks, oral care is put next to hair care. Again, it's fluff. It's something to make them feel better. Should it be next to hair care, or is there a better location? Is infection control and wound care a better spot? I think so. Again, in a certified nursing assistant course, they get about an hour of training versus a half an hour if they do the 75-hour thing in the nursing home. That's hands-on and lecture, and they practice on each other. These people in the nursing programs aren't even taught to approach the resident from the side. They approach the resident from the front with the toothbrush like a sword. I taught these nursing assistant students to come from the side. They don't even know that. We know that because this is our area of expertise. The oral conditions of the students are not even close to those conditions that they're going to see with their residents. They cooperate with each other. If they simulate the resident's behavior, it's funny. And they don't provide oral care on an actual resident until their externship, and there's no oral care expert available to help them learn. So they're on their own. Really? Would any of us approach a person like this? No. But they don't know any better. No one is there teaching them how to do this. My mentor, Shirley Gutkowski, had to talk me off the ledge when I saw this next statement from a Lippincott textbook copyrighted in 2005. And this was several years ago when I saw this. Keeping the mouth and teeth clean and healthy is an important part of personal hygiene. A clean, healthy mouth feels good. There you go. And makes food taste better. Well, there you go. And contributes to overall health. Now we're getting somewhere.
As does clean hair.
What's that?
As does clean hair, which is why it's next to, hairdressing.
Exactly. I mean, I love to have my hair done, and if I don't have my hair looking decent, I don't feel very good. You know, my self-esteem goes down. But
you're not going to die from it.
You're not going to die from not having your hair curled. Right, exactly, Danny. Look at this. Poor oral health can cause gingivitis, inflammation of the gums, which can lead to pyorrhea. Oh my goodness. That term, pyorrhea, is a term that my grandmother used. And we're still teaching the nursing assistants that? in the year 2005? It's insane. This is what it means, in case you wanted to know. Discharge of pus, also known as Riggs disease. Oh my goodness. We really need to help these people. So who are these people and what do they do? I think that we have, as dental professionals, especially hygienists, when we see a nursing home resident come in and sit in our chair and it's almost Christmas time and they still have Thanksgiving turkey in their mouth, we get a little upset. And we tend to write nasty notes back to the nursing home. Things like, you need to brush their teeth better, you have to do a better job, yada, yada, yada. Well, I think that if we understand who these people are and what they're trying to do, we're not going to be so hard on them. So this is a class of nursing assistants that I helped teach about oral care, and they're no different than most hygiene students or most dental students. They're young, they're there, they want to change people's lives, they want to make their lives better, they have no idea how hard this is going to be. Contrary to popular belief, they are not standing out back smoking cigarettes when they're supposed to be taking care of people. I've job shadowed at nursing homes. I know what they deal with. And until we understand it, we don't have any right to be sending nasty notes about oral hygiene. And if there's nothing else that you take back from here, is to please never send a note back to a nursing home, to the CNAs, complaining to them. We've got to do better than that. We have to be support to them. Their job outlook is changing quickly, well, of course, because our population is aging. And they will assist residents with activities of daily living, ADL, such as eating, bathing, using the toilet, dressing, lifting and helping residents in or out of bed, and administering medications. Most oftentimes, they also provide emotional support for the residents because there are no families, or not a lot of families, that come. So these people become the residents' families. This is so interesting to me. Typically, CNAs have between 10 and 12 residents each shift that they're taking care of. And if we look at this graph, the RN spends about 30 minutes per resident per shift. LPN a little more than that. A CNA, 2 hours is required. That's what the care is required for each resident on a shift. Well, if I have 12 residents and I have to spend 2 hours each with them, that's 24 hours. How am I going to get all that done in 8 hours? Something has to give. And the oral care goes unchecked, unmonitored. When I ask nursing assistants if they have 3 minutes left with a resident and they have the task of putting the socks on or doing oral care, that's what they have left, and they can only do one, which one will they do? They always tell me, put the socks on. Because people can see that they didn't put the socks on and they will tell them they aren't doing their job, but no one ever checks oral care. But they get to make the big bucks, guys. Wow. Are you kidding me? All of this for 13 bucks an hour? Occupational factors such as low pay, limited advancement, poor management, employee relations, and a difficult work contribute to turnover. In casual conversations in the hallways, this person found one aide who had been on the job for more than 6 months. 70% of aides or CNAs change jobs in a given year. They're looking for something better, a better facility to work at, because this is hard work. Poor quality of care, meaning more bed sores and more use of restraints, catheters, and mood-altering drugs. That's one of the reasons for the high turnover. And nursing assistants tend to leave within 3 months because of inadequate training, support to juggle multiple frail, ailing residents at a time. So, Is oral care education enough to improve the oral health of our elders? So I've done a lot of in-service trainings on oral care, but what the research shows is that oral care educational programs are not enough to result in the improvement of the delivery of routine oral care. So while education is always a good idea, it doesn't transfer into improved oral health of the residents. So my mind has just been boggled by this. So in my travels, I've educated, I've provided services. These are several different pictures up in the upper right here. This is the dental office that I worked in. We did get a new chair donated from a dentist that was updating his office, and so he got rid of his old chairs. He gave us one. This is my suction. This is one of the machines that they use to suction out the throats. That's all they had. I'm like, well, I can make that work. I just put a saliva ejector on the end of the tube. I've done screenings. This is over here on the left is screenings for the state of Wisconsin to determine what the oral health situation was of the elders. I've done health fairs. I've been at the nursing home conferences. And this is what I see when I'm working with these people. This is two-tone disclosing solution by Young Dental. They now have a three-tone. The areas that you see that have blue staining are areas of plaque that have been on the teeth for longer than 24 hours. Areas of red are areas of plaque that have been on the teeth for less than 24 hours. Something isn't working. And that's why we have this statistic. We're not doing a good enough job. So this is when I decided that something's got to change. We need to have a different approach. If the fundamental problem is the bacteria in the oral cavity is not being controlled, which I believe it is, and I think that probably you would all agree, and these bacteria lead to dental decay and periodontal disease, and that a dirty mouth can lead to death with causing heart disease, stroke, aspiration pneumonia is probably the biggest killer. When we aspirate those bacteria into our lungs, that's probably the biggest killer of this population. We know that periodontal disease has some connections to arthritis and cancer and Alzheimer's at this point. And all those conditions can lead to dying from dirty teeth. You will never see that on a death certificate. But it could very well be the underlying problem that caused these things. So what to do? Like, I've got to figure out a way to reduce this bacteria in the mouth. And so Shirley Gutkowski and I did a project in the nursing home that I had kind of wiggled my way into, and we called it Candy Saves the Day. We know that xylitol can reduce the bacterial load in the mouth. And I wanted to know what I could do with xylitol with my elders. So what we did, it was a small study. We asked the nursing home to give us 6 residents, and I went in and I trained the certified nursing assistants to run a xylitol protocol with these residents. I did not teach them anything about brushing and flossing. In fact, I told them I didn't care what they were doing for brushing and flossing. That's not what we were looking at. Continue to do whatever it was they were doing. I asked them to give each resident in the morning when they were dressing them 2 pieces of xylitol gum. You know, we picked residents that could chew gum. We've done subsequent things, but this is where we started. So 2 pieces of gum in the morning upon dressing for 5 minutes. In the mid-morning, if they had a dry mouth, they could give the resident a couple of pumps of the Spry Rain spray. At lunchtime, we wanted them to put a little, after lunch, a little bit of MI paste on their finger or the resident's finger and just smush it in the mouth and leave it. We wanted to help to improve some remineralization more than we could with just the xylitol. Again, in the mid-afternoon, if their mouth was dry, they could have rain spray. 2 pieces of gum while they got their jammies on, and then bedtime MI paste. So we ran this for 12 weeks. it's interesting that Walter was our least compliant resident, but we had over a 70% compliance in the 12 weeks. Interesting to us too, and we don't quite know what to make of it, is that the morning things were accepted very well, but in the evening things kind of dropped off. But we still had just under a 70% compliance rate. So what I'm going to do next is show you the pictures of these 6 residents. We went in, we disclosed them, again, with the two-tone disclosing solution. So blue plaque, been on the teeth for longer than 24 hours. Red plaque, been on the teeth for less than 24 hours. We took a picture in the beginning, the middle, and the end. Okay?
Before you jump to the next slide, Angie, can you hear me?
What's that? What's that, Denny?
I thought that these numbers were cumulative from left to right at first, but they don't seem to be.
They're not cumulative.
Like Marie. So what is the 20? What do they refer to? I gathered. What is the 2 next to Don for AM xylitol?
So that's how many times he missed his morning chewing gum in 12 weeks.
Okay, I gotcha.
Okay.
Sorry. Yeah, I needed to be clear on that. Okay.
Yeah, perfect. That's wonderful. Thanks for chiming in. So this is Walter. This is our least compliant resident. Upper left, how I found him. 6 weeks in the upper right after xylitol use, 12 weeks after xylitol use. Oh my gosh, I was on fire when I saw this because it's so good.
That's right.
Walter is schizophrenic, and he never let anyone else brush his teeth. He always told them he did it himself. So in 12 weeks of getting the xylitol into his mouth, not even at the recommended dosage, this is what we were able to accomplish.
It's remarkable.
Walter is at much less risk of aspiration pneumonia after the 12 weeks than he was in the beginning. This is Kevin, and Kevin is a younger gentleman, a Vietnam vet, and we can watch the flora go from blue to red. The interesting thing about Kevin is that I didn't know this when I started working with Kevin, but when I went back after 6 weeks, the aides came to me and told me, Angie, I don't know what that stuff is, but Kevin smells so much better that we can take care of him now. They didn't want to take care of him because his mouth smelled so bad. So they would neglect him. So
I have another quick question for you.
Yeah.
You mentioned that they have 3-color disclosing now. What does the 3rd color indicate?
Purple.
Yeah, and what is that? Well, you said 24-hour, less than 24-hour. What would the other color?
You know, I'm not really sure, Danny, because I haven't used it.
Okay.
So I don't know what that purple color, if it is a longer time that the plaque's been on the teeth, and maybe if someone in the audience has used that, maybe they could type in the response. They might know better than me.
Okay. Yep, please do if you do know, and I'll share it.
So this is client number 3. Again, this first picture is dark. Remember, Shirley and I are hygienists who are making this up as we go along. We're not photographers. We're not technically researchers, but we're trying to make a difference. Here, this is a great result. Blue to red to almost nothing except for the buccal of number 7 and 8, the facial. And I contend, had we run this for another 12 weeks, that biofilm would have been gone as well. Beginning, middle, end. Watch the flora go from blue to red. And the plaque here on this tooth can be simply blown away with the air water syringe because the xylitol makes it not sticky. And then beginning, middle, end. Again, watch the change. In just 12 weeks, these people never had any professional intervention. I didn't touch them. So if I can do this with nursing home residents, imagine what you can do with your patients and xylitol in your practice, and they're getting their hygiene visits. And you can tell no one was in here cleaning between her teeth with anything. So that research project was eventually published in the Integrative Medicine Clinicians Journal, and it's a peer-reviewed medical journal. We did take a hit. We had, on the peer reviewers, one was an MD, there was a dentist on board, and the dentist wanted to know tell us that we didn't really make that big of a difference, because what we should have done is scraped all the plaque off of all the teeth and weighed it, and then at the end scraped it off and weigh it again. And
yeah, that's great.
I wanted to scream. So this isn't like a, like a university double-blind whatever study. This is a jump-off point where I just needed to see what I could do, and maybe someone with some money and some resources would pick up and do some more studies like this of the elders. So it was an interesting process.
Yeah, I bet.
So I really think that if we could have gotten some simple advanced treatment modalities in this mouth, like the xylitol or some fluoride, we could have really helped this patient. And the same here. We could help by doing simple advanced treatment modalities, getting these things into people's mouths. So I was like, this is great. I have a reduction in bacteria with the xylitol. Then I started picking up on some other research. Research was showing that toothbrushing may prevent death from pneumonia, especially aspiration pneumonia. And oral hygiene reduces the chronic inflammation that periodontal gum disease causes, which increases the risk of coronary heart disease and stroke. Stuff that we know, but simply toothbrushing. Approximately 1 in 10 cases of death from pneumonia in elderly nursing home residents may be prevented by improving oral hygiene. Weekly professional mechanical cleaning of the oral cavity rather than daily chemical disinfection of the mouth can be an important strategy to prevent aspiration pneumonia, independent elderly, and results of this other study showed that oral hygienic condition could be improved by performing professional oral care at intervals of 1 week for 12 consecutive weeks, and that the improved condition could be maintained when the professional oral care was continued at intervals of 1 week thereafter. I was like, wow, this is really cool. So I'm learning all this stuff, and then this gentleman who I'd been seeing for years comes into my office. You all know the type of a patient if you've been practicing for any period of time. So Ed, I started seeing him as soon as I started working at this dental office. He was fine. He came in with a cane. Then he started coming in with a walker. Then he started coming in his motorized scooter. Then the last time that I saw him in the dental office, he had been put into the nursing home. And when I looked in his mouth, I couldn't believe what I saw. I had never seen his mouth this much of a mess. I knew that something had markedly changed. And I asked him, and he said, well, I'm in the nursing home now. So because of my research with the xylitol, and because of what I was learning about weekly oral care, I went to my dentist and I said, Dr. Dubats, I want to go and see Ed once, actually at that point I wanted to see him twice a week because he was such a mess. Twice a week in the nursing home and brush and clean between his teeth, and I want to give him xylitol, have the caregivers give him xylitol after each meal. And my dentist said to me, Angie, you are going to go to the nursing home twice a week to brush and floss his teeth? I said, yes, I am. And he said, knock your socks off. So I was able to get Ed back under his gum tissues under control, his oral health was spiffed back up, and I learned over the 2.5 years that I saw him until he died that if I was there within once every 10 days with Ed, that I had no bleeding gums and he had no troubles. If I was there 11 days, I was going to get some bleeding. So I saw him once a week. And again, he got 1.5 grams of xylitol 3 times a day after each meal, which was administered by the person passing the meds, and weekly brushing and flossing by me. So here we are. I bought him a battery-operated sonic care that I only used when I was there. He did the best he could with his manual toothbrush in my absence, but we did this once a week for 2.5 years. This is Ed when I had gotten him back under control after our dental visit, and this is Ed 2 years later. He never needed to see the dentist. I never needed to have to try and figure out how I was going to manage to get him over to the dentist because I was taking good care of him. For that and for my research, as Danny mentioned at the top of the program, I was awarded the Sunstar Award of Distinction in 2012. And at the same time I was seeing Ed, because Ed lived close to me, my gram was in a nursing home as well, and I showed you this picture a little bit ago. So I got a call one day, and my aunties said that Graham was having some tooth troubles. I'm like, well, she just saw the dentist at the nursing home not that long ago, but I can't imagine what's going on with her. So I went up to the nursing home, and I knew she'd had a couple of teeth taken out. You know, my aunties had told me that, you know, along the way she'd had a couple teeth taken out. But I really was on the road a lot, and I just hadn't been paying much attention. So this is my gram in July of 2010. This is my gram in June of 2012. She lost 60% of her teeth in 2 years under the care of the nursing assistants, the nurses, and the dentist with the organization that was responsible for overseeing her oral care. This haunts me. I buried my gram with no front teeth. This is sick. There is no need for this. Nobody in this country should have to go through this. And I'm a hygienist, and this happened to my grandma. So I decided I had to keep on going. I have to stop this. So we opened up Ed's protocol in a larger case study, and we had 45 dependent adults in 4 facilities over 3 states, and they got Ed's protocol. And I'm just going to share the results of that with you. So all I have is my eyes, and it's really hard. This is a difficult population to work with, and so as far as scraping plaque and plaque indices and all that stuff, it's really difficult to do. So what I did is the same thing. We disclosed people in the beginning, the middle, and the end, and I categorized them in according to minimal, mild, moderate, or severe debris. So minimal is no or very little red staining in the initial photo. The oral hygiene is classified as good. No subjects began in this category. Big surprise, right? So then the mild, what that means is several to most stained areas are red in the initial photo, and few or no areas of blue, and the overall hygiene is classified as fair. 5 of the 45, or 11%, began in this category. So this is an example of moving from a mild in the beginning, and she moved to minimal in the 12 weeks. That make sense, Danny?
See.
Okay.
It does.
So then moderate is mixed areas of red and blue staining. Oral hygiene is classified as poor. Almost 30% of the subjects began in this category. Here is a situation of going from moderate to mild in the 12 weeks. And then severe. Most areas stained blue, hardly any red, if any, and oral hygiene is considered terrible. And or there are obvious signs of of gingival inflammation. 60% of my residents began in this category. This is for instance, of going from severe to moderate in 12 short weeks of this protocol of brushing once a week and using xylitol. So this is a pie graph of where the residents were in what category in the beginning, and this is the completion. You can see how we were able to move some into the minimal. We were able to move a lot out of the severe and into the moderate. And I think had we, again, done this for longer than 12 weeks, maybe 24 weeks, we would have taken a lot more people out of that severe and probably moved a lot more into the mild. So we had over 31% of the subjects moved to an improved category in 12 weeks' time. Not everybody moved into a better category, but 78% of them showed obvious visual improvements. And this is one of my oral care specialists, Rita. The families wanted to know how to get their loved one into the program. They saw Rita coming, and they were like, what the heck? How come that resident is getting that special treatment? And the residents were excited to see the hygienist / oral care specialist. We were taping our interactions. We tracked everything. And the team, the nursing home team, couldn't believe that we were there to help them out. So you see our cart there, and we would go in and we had our toothbrushes, each resident's toothbrush in a pencil case, and we would just go in and do our thing. And the residents would also report that it felt so good to have this service provided. So let's again go back where we started, these current numbers for our residents. Just about 16,000 facilities in the United States with just about 1.5 million residents. If we do the math, that transfers to approximately 89 residents per facility on average. Remember that 5% of Americans over age 65 live in a staffed facility. 55 million people in the United States will be age 65 or older by the year 2020. And remember this statistic, of all of the people turning 65 per day, 5% of that number is 3.6 million, or in the year 2031, an average of 233 residents per nursing home, or we're going to need 41,000 nursing homes. Oh my goodness. What in the world are we going to do with all of these people that are going to need dental care? And remember, the boomers are the next generation. Elderly people are more than likely to retain their teeth than were their predecessors, so they will require much more care than in the past. This is not going away. So how is your office serving your aging population? Are they simply disappearing without any further dental support? I think that we all know or have been going through charts and we're like, hey, whatever happened to Charlie? Or whatever happened to Sandy? And they just kind of like ride off into the sunset. And we have no clue. Did they end up dying from dirty teeth? What we do know is that we don't have much dental care going on for these people. And I think they deserve our support after they've probably supported our practice for years and maybe even decades. Good oral health should be for all ages, not just the kids. And are your parents going to need help with their oral care? Are your aunties and uncles going to need help with oral care? Those of you who are younger who are on the call, maybe it's your grandparents that are going to need help. Do you want them to die from dirty teeth? I don't think so. So 13 years of work has culminated in me founding a company called High Life. And that High Life stands for hygiene and life. Hygiene has to be for our entire life. And the logo, the green, is the growth and the life, and the purple we know is the color of dental hygiene and dentistry, and it's always swirling. It has to swirl around our life in order to stay healthy. So High Life is a compassionate network of dental hygienists who are also certified care providers who provide oral care services to dependent elders. And what that means is brushing and between the teeth cleaning with floss or floss picks, whatever the oral care specialist denotes. I don't know why my slides are advancing by themselves all of a sudden. So what we do, what's that, Danny?
No, they know we're getting near the end, so they're.
Yes, and so I just want to really have you all see this this slide without it advancing. So I am going to go back here so we can just look at it in this area here. So we can notify the office of issues with the patient. I can't tell you how many times I've done this with my clients. I know within a week of seeing them, and I see them the next week, if something has changed, if they've broken a tooth. I know if these residents have dental insurance. I can figure that out. I can coordinate care between the resident and the dental office if they can get out. If they can't get out, then I can talk with the dentist and say, hey, what would you like me to do? And if the dentist is willing, then they can come and take a look. So I can provide referrals to your office. I provide dental and care team support. High Life does. I have more than just me. Oral health advocacy, patient and family camaraderie, and family group presentations. The benefits to the elders are that they receive professional oral care. We are preventing oral disease. We're reducing those risks of those oral systemic links. We're reducing dental emergencies, lessening pneumonia rates, and we're also improving overall quality of life. We're an extra set of eyes and ears in that facility, and we're there on site once a week. We develop relationships with these elders. Do you know someone who could benefit from High Life services? Do you know anybody who would like to become an oral care specialist? Or do you know anybody who would like to partner with an oral care specialist? We're always looking for people to help improve the oral and systemic health of this most vulnerable population. So if you have any questions, you can certainly contact me. You can check out our website at highlifellc.com. You can feel free to email me. And I'd like to, again, thank Aseptico for having this presentation. And, of course, Danny, I'd like to thank you and AIM Dental Marketing for allowing me to share my passion with your listeners tonight.
You are more than welcome. As always, that was a very touching, moving, and inspiring presentation, and I, on behalf of our attendees, want to thank you for that, as well as for the important work that you and High Life are continuing to do. We have a lot of questions. I just kind of want to dive right in. Bill says that I am a dental hygienist. I know there are laws in some states to prevent hygienists from providing dental hygiene services without the involvement of a dentist. Can I provide oral care services in those states? I think you touched on that, but I think that's an
You absolutely can. That's a great question. And again, because we're not providing dental hygiene services, okay? We're not taking hygiene equipment in. We're not taking any scalers. We're not taking any dental hygiene stuff with us. We are care providers, and we're also certified caregivers. And so what we're doing is we're supporting that care team by being an extra caregiver, and there's no reason that a hygienist cannot be a caregiver. We can have multiple certifications. And so when we provide these services, we are providing caregiving, not dental hygiene services, because as we talked about, the dental hygiene services aren't even the end-all be-all. When the magic is going to happen is when we have an oral care specialist, we have a dental hygienist that can provide the cleanings every 3 to 6 months, and we have a dentist all working together. But that may not ever happen in my lifetime. So this is my solution for making a difference.
Wonderful. Kristen, this is more of a comment, but she had mentioned, I know she practices in Florida, that a Florida company had approached her in the past to work for them. I think this is in the context of Sam Perlin's information about his experience and your experience in Texas. And she's done nursing home care since 2000. I'm not, it's a comment. I guess that there are companies in other states, as we guessed, and Florida among them, that are doing this. And I wish you'd commented as to the quality. Maybe, Kristen, if you're still on, we can see what your experience was with that group. Well, you said they approached you, so we don't know if you actually worked with them. And then Eve asks, I think in the same similar context, is the company that you referenced Prime Source?
No, that company is not familiar to me.
Okay. Okay. And then Ron, in the same comment, said there must not be regulation over these outfits. I don't know. I don't know how old they are or what regulation, if any, they would fall under. Do you?
I don't. Again, I don't know. I've not spent my time trying to research what they're doing. Um, my goal is to come up with a solution that's going to absolutely help the population. So I've not done a lot of research on what's happening. I just know that what I have found with my gram and what I've heard from Sam, and I've heard from a few other hygienists across the country, particularly Florida, that they've not really come across any good organizations that are doing this. I think if individual dentists are doing it, that is probably a better fit and a better service. The companies usually come in, they set up their stuff, they do whatever it is that they're doing, and then they're out. And they just don't have enough time or the staff to get to all of the problems.
Mm-hmm.
And there's not enough money. They're not making any money if they're taking care of everything.
Right. You're keeping your eye on a different ball, which is empowering people to just deliver this oral care directly. Heidi, apparently based in Montana. Montana does not need a DDS for anything except to review an x-ray within 30 days. We don't have to collaborate with the DDS, exclamation point. And then later, Heidi goes on. In Montana, an RDH collaborates with social workers, physical occupation and speech therapists, MDs, nurse practitioners, and DONs. They don't have a big mafia problem there. Don is director of nursing.
Yeah, director of nursing, yeah.
We do not need a DDS. I guess they don't need dentists to do a lot of this in Montana. Do you know anything about Montana?
I know Heidi. I think that's probably, I know Heidi. And so I think Heidi is doing great stuff out there in Montana. But again, we need the dentist to review your x-rays. And so there is a tie to the dentist. You have to have that done within 30 days. So hopefully in the state of Montana, you have lots and lots of hygienists that are doing this. That's not what I've come across. I know that Heidi is doing fantastic things, and a lot of people need to be doing what Heidi is doing, absolutely. But I just don't think that there's a lot of hygienists that really even want to purchase their own equipment. They don't, there's all this things being worried about independent practice. Most of us don't even want that. So, but if that's, you can do that in Montana, that is fantastic. But I think even Heidi, you and I have talked that even when you see your patients for their hygiene visits, they're not as disease-free as what you might like them to be. So adding the oral care would be a great adjunct. So I'm happy for that happening in Montana. Thank you.
And obviously, it's a big step if somebody wants to basically open up their own business, because it would entail no less than that, and all the investment and risk and insurance and marketing that would be involved in that. Does HighLife assist with people that want to actually go to that extent?
No, we don't assist with people that want to have their own hygiene practice, if that's what you want to call it, with doing dental hygiene. But we absolutely do. We have anybody that would like to become an oral care specialist on the hygiene side of things. We do have all of support for all of our marketing materials and training and camaraderie among the group. And so we are having the hygienists have the ability to have their own oral care specialist business. They can decide how much they want to work and how much they don't want to work and how many residents they want to have. So it's really kind of a cool thing. Yeah. It's kind of their business in a box.
But they don't really have to go it alone. You provide a lot of support. Business in a box. Well put. That's exciting. Can make a big difference. Sam says, do you think, I'm reading between the lines, do you advocate better training of the home care CNA staff about dental care and the importance of home care? I would say you probably do.
Yes, we do advocate that, and we do in-service trainings. As far as I know, in all of the states, there are certain in-service trainings that the CNAs have to have annually, things like fire training and OSHA, kind of like we have to have our OSHA training. And one of the topics that they have to have is oral care. And that's a whole nother, I had to take that section of the presentation out because it would have been too long. But yes, I do advocate for training them. However, I don't I don't ever feel that that is going to be the end-all, be-all. It's kind of like if someone came in and gave me a crash course on placing catheters and changing them and then leaving.
Mm-hmm.
And then when the patient sits in my chair, if they have a catheter, I have to change it. Just because they taught me how to do it doesn't mean I'm going to be good at it, and it doesn't mean that's where my brain is. We're the oral care specialists. We're the ones that should be taking care of the mouth.
Got it. I'm just trying to field some more questions here. One is, how are you being paid, or is this volunteer your time?
It's not volunteer. Right now, again, this is this company was launched at Under One Roof on the show floor last summer. So we're still building a lot of the infrastructure. By the end of 2015, I believe that this is going to be, we're going to be dead on. We're going to have this pretty well figured out. But right now, it is private pay. And so that is one challenge. However, if I can get to the family members of these residents, and particularly if there's dental offices that are seeing these residents, or you're seeing your patients decline and you know those patients' loved ones, if we can reach the loved ones and they understand what's going on, they are very apt to pay for the services, just like they're apt to pay to get the hair done or the nails done. But they don't know what's happening. They just think that everything is taken care of. But once they know,
excellent point. Yep. They're not willing gatekeepers, but they have no knowledge or really awareness unless you make them aware. They being the caregivers, the employees of the facility, they don't know that they can actually simply make their the family, the loved ones, or the residents themselves, if they have the means, to make a choice about this care if they want.
Correct. And that's hopefully, Danny, what the book is going to do. Hopefully the book is going to, the book isn't written for dental professionals, it's written for people. And so we talk about a lot of things that we did tonight, and we go into some other things too, but it's written for people so that the people understand what is going on, so we uncover this issue.
Excellent. All right, another question. Let's see, we got that. Somebody, Catherine, just wrote, again, it wasn't a complete sentence, but I think I can understand. She's just said oral care to unconscious patients. I would imagine she'd like to hear a little bit of elaboration on how that's done.
Yeah, that's obviously really tricky. But again, what we have to do is we've got to be able to, number one, get in their mouth. And who's better at that than a dental professional? Who's someone who's been in mouths most of their life. And then also using things other than mechanical disruption. So using things like the xylitol or using oral probiotics, things like that to control that bacteria is where we're going to come in best. And so the cool thing is that the xylitol is available in gel form. It's available in a spray form. We could even just sprinkle straight up xylitol in someone's mouth to get the effect of the xylitol.
Yeah, that's very true. I think it's so promising and, you know, non-invasive. It's not like giving them medicine,
No.
even though it has. People like it. It's the only sweetener that I use in the house, and I don't even like the taste of other sugars now. You know, you get accustomed to it. All right, our friend Patty wrote. Natural. That's right. I think our bodies produce it, actually.
Our bodies do produce it, Danny. You are so right.
So Patty writes, pH less than 4.5 is very acidic. I don't know the context in which she shared that, but
I don't know either. We didn't talk about pH, but yes, that is one of the issues that our elders have if they're on medications, which most of them are. Most of them are on meds that dry their mouth, and so the pH is low. And so the biggest challenge is to keep that pH up. And again, the xylitol is fantastic at raising pH.
And that's something that you can test fairly easily also,
yes.
right?
Yes.
Yeah, well, that's a good point. Thanks for that, Patty. Hope we got it right. Kristen wanted to know if it was Young that offers the disclosing solution.
Yes, Young Dental, as far as I'm aware.
Right down the street from us here in Northern Illinois.
Yep.
Deb asks, did you use MI or MI plus paste for your protocol?
I don't recall if it was MI or if it was MI plus. I'm sorry, I don't recall.
No worries. Well, you can research that and get back to our attendees as well as answer a few more questions that we have not time to get to, because at this time I want to, in addition to thanking you again very sincerely for the wonderful presentation and just reminding us about what an important topic this is, I want to remind everyone to mark their calendars for next month, Thursday, to be precise, be more precise, Thursday, April 30th at 7 p.m. Central Time, when we will continue our focus on this most important and timely of topics, namely care for the elder population, with Doreen Naughton, whose presentation, It's About More Than Cleaning Old Teeth, will share some of the keys to mastery of her elder health delivery model. In the meantime, this is Danny Bobrow thanking you for your commitment to practice.